if my patients, sometimes if they've got PID, pelvic inflammatory disease, you can't put anything up there because it hurts. You can try, and just, if they can't do it, or if they're too anxious to do it, just put patient unable to withstand transvaginal probe. And you're covered. You can still charge them for it because you put the probe up in there. You can still charge them. Even if you take one, you have to take at least one image, and you can still charge them. Patient unable to tolerate exam.
Do you put that, like, type it and like print it? Or do you
Oh yes, I type it as part of their medical records on their film. Okay? Okay. Because they need to know, if that goes to court, they need to know that the patient was unable to tolerate the exam. Some people will just write it on the requisition. I usually type unable to complete exam with the patient. Now if the patient is just combative, I won't put that on there. I'll write it on the requisition, patient combative, unable to finish exam. I'm not gonna put combative, because if that goes to court, then I can go to jail or get fined because I'm making assumptions on someone else. Does that make sense? Everything you write down, you have to think that it's going to go to the court. Everything, okay? So with the transabdominal exam, we like to have a full bladder, but the full bladder, it might be too full. Sometimes you can take your patient, give them a cup and say, I need for you to go to the bathroom and pee in this cup, but no more than this cup, and stop it. Well, some people like me, I wouldn't be able to stop it. I'm gonna try my hardest, but it's not gonna stop. Once it starts coming, it's gonna keep coming, okay? So you have to be cognitive of the demands that you ask for your patients to do. A full bladder will make no difference for a retroverted uterus. It will help you none, okay?
Why?
Because the uterus is this way, so a full bladder is not gonna flatten out my uterus, okay? Transabdominal, I'm closer to the pelvic organs. I have a higher frequency transducer. Because of my higher frequency, I have less depth, but I have better resolution. I need an empty bladder. There's no preparation for it. But the thing is, if I have an obese patient, I put it in there, and this is all touching my body. What can I do? I mean, it's not gonna move, you know, so we have an inadequate exam. Anytime you have a C-section, you want to go on either side of the C-section. You don't want to be right on top of the scar, because ultrasound won't go through the scar. You have to be to the side of it. So, endovaginal is a lesser field of view. If I point to the right side, I see nothing from the uterus over, okay? It's hard for some patients to relax because you've got something in their vagina. Then you have the ones that you put something in their vagina and they start moaning. Stop the exam and go and get a chaperone.
Have you had a patient?
Oh, yes. People are crazy.
Yeah.
People can be crazy. So go and get a chaperone. Okay. Now remember, in a postmenopausal woman, the vagina tends to be very dry. Okay? Be sure you use lots of lubricant because there's nothing worse, because you can actually tear the walls of the vagina, because it's very, very thin. Okay, so make sure you use plenty of lubricant on postmenopausal women.
They use the sterile gel. In the
Sterile
vagina.
gel?
Mhm.
Yeah.
On the requisition, will it mention postmenopause?
No.
That's
Sometimes
okay.
it will. Sometimes it'll say postmenopausal bleeding.
So how you can tell, based on the age or no?
No,
When we
you
ask,
can't, you can't do anything
when we
based
ask
on
about
age.
the period.
Yeah, when you find out about their
Oh,
period,
yeah.
and they haven't had a period in 15 years, you know they're postmenopausal. You know they're postmenopausal if they haven't had a period in a year. Okay? And if you're postmenopausal, your vaginal fluids tend to dry up, and so the vagina gets very dry. Sex hurts, a probe is definitely going to hurt. Okay? Always stick to the protocol of your department. Here's our protocol here at Harris Health. You do the long cervix with and without measurements. You do a long uterus midline with and without measurements. You do long right and left uterus. I'm gonna scan all the way out, come back in. I'm making sure there's no pedunculated fibroids. I'm coming back in, just taking a piece of meat. I should not see any endometrium in those left and right images. I'm gonna take my long endometrium with and without measurements, but I'm gonna zoom my image so that way I can see the endometrium better. I'm also going to use color. I could have a polyp in there, okay? Then I'm gonna go transverse and do my cervix, my lower uterine segment. I'm gonna go to my body with and without measurements and color. And then I'm gonna go transverse fundus. Transverse fundus, I should only see a piece of meat. I should not see any endometrium. I'm gonna choose which side to go to. On the protocol, it says go to the right side. You're gonna do long right with and without measurements and color. And then I'm gonna do transverse right with and without measurements, with and without color. I'm gonna take a picture of the right adnexa. I'm gonna go lateral to the ovary and take a picture in sagittal and transverse. Then I'm gonna go to the left side. I'm gonna take a picture of my left ovary, sagittal, with and without measurements and color. Then I'm gonna turn transverse. I'm gonna do transverse with and without measurements and with and without color. I'm also going to look at my adnexa in sagittal and in long. Okay. High resistance and low resistance. I'm not going to go into detail too much for this because I think it's a little bit higher than where you are in your education right now. Okay? So what we're gonna do is you're gonna do the workbook and that's gonna be your test grade. Okay? That's gonna be your test grade. I might have a vocabulary test for you. Okay? The last 15 minutes of class tomorrow, on Friday. A vocabulary test. I just need for you to know what it is so you can see it in clinic. It's a little bit further than what you need to be right now. As far as I know, that's the way I feel as far as your education. Okay, you've got high resistance and you've got low resistance. Okay, if my blood goes into an organ very easily, then that is considered low resistance. If blood goes into an organ very easily, okay? Let's take the portal vein, because y'all know the portal vein. Y'all studied it a little We did it in anatomy and vascular, and we did it in the liver. The liver is a large organ. The portal vein should have no problem feeding my liver. That is low resistance. But if I have a sick liver and the blood can't go into my liver like it should, and it backs up into my spleen, makes my spleen big, that's called portal hypertension. So blood is having a hard time getting into my liver. That's considered high resistance. Okay? It's just the opposite of what you would think by the words. Low resistance, the flow goes in there with no problem. High resistance, it's having a problem traveling. Okay, there's something blocking it downstream, causing it to be high resistance. The main thing that I need for you to know out of this chapter, as far as your quantitative waveforms, is to know the difference between venous flow and arterial flow. Okay? Arterial flow is like a heartbeat. Okay? Venous flow is a steady, phasic flow. Phasic meaning it responds to respiration. Phasic means it responds to respiration. Now, the RI, the PI, and the SD ratio that you see on the screen, that is all done automatically for us on the machine. You do have to know the formulas for your physics exam and for your abdominal exam and for your physics exam, for your OB-GYN. Because every one of those are going to have physics questions on them. Your specialty exams will have a physics exam, physics questions on there. Okay? Okay?
I'm sorry, can you describe the venous flow again?
Okay.
Just a quick.
This is venous flow.
I understood that it's sensitive to respiration.
It's phasic. It responds to respiration. This is arterial flow. This is arterial flow. This one has a low resistance. Okay? This one has to work harder to get into the ovary, so it is high resistance. See how the systolic, okay, so let's go over the heart. Oh, it's already over. Okay, 5 more minutes.
He said 12:30,
Huh?
JT said.
Oh, he won't be back until 12:30?
Yeah.
Okay. Okay, so the heart is filling. It can't fill anymore. The valves open up, the heart empties. Okay? Diastolic is when it is empty. So it's empty, it's filling back up, it's to its maximum, it empties, now I'm at diastolic. It fills up, systolic, it empties, diastolic. Fills up, systolic, empties, diastolic. Low resistance, high resistance. Low resistance, high resistance. Okay, and these are just the formulas.
Okay.
So this is my systolic, this is my diastolic. Okay?
Is it
Miss
arterial?
Shepherd.
It's an arterial flow.
Arterial flow. Because systolic and diastolic are not part of the venous system. Okay? Here is a arterial